Today we'll be going over seizures and epilepsy. We'll start by classifying seizures as far as their clinical presentation, what are the different causes of seizures, and then also how we diagnose them. And then we'll move on to epilepsy, a common term maybe confused a little bit with seizures, but we'll parse that out a little bit and then discuss some common epilepsy syndromes both in infancy as well as childhood. So what really defines a seizure is basically abnormal electrical activity in the brain. And the way we like to categorize seizures, at least at first, at least the way I like to do it, is based on where the seizure actually presents in the brain. So we have two types, focal and generalized seizures. Focal seizures are typically seizures that originate in one hemisphere of the brain compared to, say, generalized, which have bilateral hemispheric involvement. Generalized seizures have they always have altered levels of consciousness. Say compared to a focal seizure where we can have with preserved consciousness, or we have with impaired consciousness. And something to keep in mind as far as the naming classification of seizures, this is constantly changing, which makes it pretty annoying for med students, residents, and other practitioners to know essentially, but these are guidelines that are focused from the International League Against Epilepsy. Something you also may have heard about as far as kind of classifying seizures is whether they are febrile or non-febrile. So today we'll be mostly focusing on non-febrile seizures, but I kind of want to briefly go over what febrile seizures are in children at least. So as the name implies, there is typically a fever going on with febrile seizures, but it's actually the spike in fever that does cause the seizure. It's not the actual temperature itself that induces seizure activity. The risk actually increases for epilepsy if they have multiple episodes of febrile seizures. Okay, so now moving on to something called semiology, which is this is just a fancy word for saying what does the seizure look like? And there are many different types of seizures, and we'll go over them here briefly. So here are 6 different types of seizures. Tonic seizures are the ones that result in muscle stiffening of extremities or muscles. Myoclonic involve jerking of muscles. Absence seizures are characterized by staring spells, so kids are potentially in class, not focusing, and they're not able to be aroused. They're not able to get their attention, basically, when these kids are having absence seizures. Tonic-clonic seizures are the ones that you see in movies, the ones that result in the person falling down, have stiffening, have jerking of their whole body, essentially, and these are a type of generalized seizure. We can also have non-motor seizures, so the ones described here are typically involve muscle groups, but you can also get non-motor seizures in which there can be vision abnormalities, smell abnormalities, a sense of deja vu or impending doom. You can also get numbness and tingling of extremities or parts of your body if there's a sensory component to the seizure. And then finally, atonic seizures. These are where a person loses their full muscle tone. They typically collapse, and they're actually a fall risk if people have an atonic seizure. So as I stated, seizures, they are electrical abnormalities within the brain that cause a diffuse discharge of electrical current causing symptoms in a person. Seizures typically have an underlying cause that we need to get to the bottom of, especially if someone has one for the first time. We want to go through a list of different potential causes of why this person had a seizure. And there's a good mnemonic that I like to use for running through the causes of seizures, and it's vitamin C, D, E. We'll go over these now. So first is vascular. Is there a stroke that someone had? Did someone have a bleed in their brain? Has their brain been deprived of oxygen potentially? This is something that is potentially a vascular cause of seizures. Next up is infection. Is there meningitis, encephalitis? Think of your torch infections, things like toxoplasmosis, varicella, rubella, CMV, herpes virus. These are potential causes of infectious seizures. Next is trauma. Has there been a blow to the brain? Is there an epidural, subdural, subarachnoid hematoma that's involved, causing midline shift of the brain, causing seizures? Next is autoimmune. Multiple sclerosis, things like anti-NMDA encephalitis can also be causes of seizures that are autoimmune in nature. So think of metabolic causes: decreased or increased glucose, sodium, potassium, magnesium, calcium. These are all things that you want to be aware of. And then these two here, iatrogenic and neoplastic. Has there been a medical-induced cause of seizures? So potentially if the sodium of someone goes from very high to very low very quickly, there can be cerebral edema in the brain causing seizures. And then leading into neoplastic, is there a tumor of any sort, whether it be a frontal lobe tumor, a glioblastoma, or a posterior fossa tumor, medulloblastoma, cerebellar tumors? Those are things that you want to be looking for to rule out any potential cause of seizure. And then rounding out our vitamin C, D, E mnemonic, is there a congenital cause? So typically kids with maybe chromosomal abnormalities, with cerebral dysfunction. So is there a congenital lesion in the brain? And then things like drugs. So potentially alcohol withdrawal, drugs of abuse, benzodiazepine withdrawal. And then finally epilepsy, which is sort of our catch-all term for things that don't meet any of these causes of seizures. And now moving on to epilepsy. Epilepsy is defined as 2 unprovoked seizures greater than 24 hours apart. So with epilepsy, to make a diagnosis of epilepsy, we need 2 seizures and also no other cause here. So we kind of potentially ruled out any other cause of a potential seizure. So now we'll move on to this side of the diagram here. We'll move on to epilepsy and characterizing a couple of different syndromes that may present in infants and a couple of different syndromes that may present in childhood. So the 4 that we'll go over today include West syndrome. West syndrome is also known as infantile spasms. We have what's called Odahara syndrome. And then we have benign familial neonatal seizures, and then lastly Dravet syndrome. There's a distinct triad for West syndrome, and I want to go over that now. So the first one is actually infantile spasms, and this can be confusing. Spasms, we think of like jerking of our extremities, but spasms in infants look very much different. So there are either excessive flexion of arms, legs, and the head, or excessive extension of the arms, legs, and head. You can also get what's called head drooping. So if a child is drooping their head during these episodes, that might be a sign of infantile spasms. Second in the triad is developmental delay. And then third is what we call hypsarrhythmia. This is an EEG finding that is marked by diffuse, chaotic brain waves that are very abnormal. So that's one thing that we see in EEG for these kids. And I want you to remember the triad there of infantile spasms, developmental delay, and hypsarrhythmia. Next, we have Odahara syndrome, which is a very sad condition in which there are seizures that present in less than 3 months of age, so pretty early on. We also get severe developmental delay as well as intellectual delay later on in life. And these seizures are very refractory to any anti-epileptic medication, which make them really hard to treat, and it's a very sad condition. And I believe there's a associated decreased lifespan for these kids with Odahara syndrome. Benign familial neonatal seizures present in an otherwise healthy infant. These also present within the first few months of life, and they actually go away by 1 to 2 years of age. And there's no associated intellectual or developmental delay with this syndrome. And then finally we have Dravet syndrome, which presents in about 12 to 18 months of age, so a little bit later than many of the syndromes that we talked about already. But it's interesting, after the first seizure, we get developmental delay. So developmental delay post first seizure. So up until this point, they're an otherwise healthy 12, 18-month-year-old, but then they start regressing and not progressing in the ways that we expect them to. The one thing that is pretty key to understanding Dravet syndrome is that there's like what's called an evolving EEG. So over time, as these kids grow into children and to teens and then adults, their EEG changes over time. So that's one thing that you might want to take note of if you're diagnosing someone with Dravet syndrome. Okay, now we'll move on to childhood disorders, the ones that present mainly greater than 2 years of age. So the first one is called self-limited epilepsy with centrotemporal spikes. Next we have absence epilepsy. So this can either be in childhood or juvenile form, absence epilepsy. And then third we have childhood occipital visual epilepsy. And then finally we have juvenile myoclonic epilepsy. So if there's one you want to remember from this discussion, is that self-limited epilepsy with centrotemporal spikes, or SELECS, is actually the most common form of childhood epilepsy. It presents in school-age children about 7 to 9 years old, but typically goes away by 12 to 13 years old. And the main symptom that these children get is related to symptoms in the mouth and oropharynx. So things like drooling, gurgling, choking, sounds that are kind of guttural in nature is sometimes what is described with SELECS. Absence epilepsy, the next one, is characterized, like I said, by staring spells. And these kids sometimes are even mistaken for having ADHD in class when they're actually having absence seizures in their classroom. There's a characteristic 3 Hertz spike wave discharge in these EEGs. And this 3 Hertz spike wave discharge is actually activated by what's called hyperventilation, which is something that we do during EEGs to provoke seizures so that we can see them on the EEG. In childhood occipital visual epilepsy, we get involvement of the occipital lobe, which is involved with your vision. So we get visual symptoms for these children, and it presents about 8 to 9 years of age. And then lastly, we have juvenile myoclonic epilepsy, and there are 3 different types of seizures that these kids can present with, and it's typically presented in juvenile, so teens, 12, 13, 14 years old. So there are 3 different types of seizures that these children present with, and they are myoclonic, as the name implies, absence, as well as tonic-clonic, so those full body seizures. On EEG, there's a characteristic 2.5 to 3.5 Hertz spike that's pretty generalized on the EEG. And then these seizures, the 2.5, 3.5 Hertz spike is actually induced by what's called photosensitivity in EEG. So what we do, we shine a light in these kids' eyes during the EEG, and this actually induces some of the seizure-like activity for these kids. So one quick mnemonic that I like to use for juvenile myoclonic epilepsy, and then the kind of the photosensitivity, I just think of I think of a teen taking pictures of themselves. They want to be on Instagram, they want to be on Snapchat, so they take pictures of each other, photosensitive. That's one thing that I like to remember for juvenile myoclonic epilepsy. So that just about does it on our talk for epilepsy and seizures. I hope this was informational for you guys to learn about the different types of seizures, the different causes of seizures, and then what sorts of syndromes exist for infants as well as children. So appreciate you watching, and thanks so much.